and welcome. Thank you for joining this program. I'm Dr. Irina Murakhovskaya from Montefiore Medical Center and Albert Einstein College of Medicine.
Hello, it's a pleasure to be here discussing warm autoimmune hemolytic anemia with Irina Murakhovskaya. I'm Bruno Fattizzo, and I work at the University of Milan in Italy, and I'm also consultant hematologist at the Fondazione IRCCS Granda, Ospedale, Maggiore, Policlinico in Milan.
And today we'll discuss warm autoimmune hemolytic anemia, diagnosis, treatment options, and treatments in development. Next, you can see our disclosure slide. So autoimmune hemolytic anemia refers to antibody-mediated red cell destruction with or without complement involvement. And it has an incidence of 1 to 3 per 100,000 per year and a prevalence of 17 per 100,000 people. Autoimmune hemolytic anemia can be classified by antibody characteristics. Warm autoimmune hemolytic anemia is the most common form and is seen in 60 to 70% of cases. The pathogenic antibody is IgG with possible complement fixation depending on the subtype of the antibody. The optimal temperature of reaction in warm autoimmune hemolytic anemia is a core body temperature, which is 37 degrees centigrade. The antibodies are generally reacting against the Rh system, and direct antiglobulin test is generally positive for IgG or IgG with complement if there was complement fixation. In about 20 to 25% of cases, we see cold agglutinin disease or cold autoimmune hemolytic anemia, where the pathogenic antibody is IgM, which is very good complement fixator. The optimal range for reaction for this antibody is 4 degrees of centigrade. The antibody is generally directed against the I antigen system, and the direct Coombs is positive for complement. Less common is mixed autoimmune hemolytic anemia. Mixed autoimmune hemolytic anemia refers to warm autoimmune hemolytic anemia with presence of clinically significant cold agglutinin. So you will have both warm IgG and a cold IgM with reactivity at 4 degrees and 37 degrees. And in a direct antiglobulin test, you will see IgG as well as high titer cold IgM. And finally, the least common subtype of autoimmune hemolytic anemia is paroxysmal cold hemoglobinuria. Here, the antibody is IgG, which is able to fix complement and bind and react to the red cells at 4 degrees centigrade and hemolysis at the core body temperature at 37 degrees centigrade. The antibody is directed against the P antigen, and the test is to diagnosis is called Donat-Landsteiner test. This is a much less common subtype of autoimmune hemolytic anemia, which predominantly is seen in children in the setting of viral infections. The pathogenesis of autoimmune hemolytic anemia consists of the breakdown of central and peripheral tolerance, which is due to either genetic factors, such as congenital syndromes and immunodeficiencies, with most common etiologies being autoimmune lymphoproliferative syndrome, or ALPS, common variable immune deficiency, IgA deficiency, or a Kabuki syndrome, which is characterized by mutations in KDM6A and KMT2D. In addition, you can have immune dysregulation, such as seen in autoimmune diseases, including lupus, inflammatory bowel disease, and sarcoid, as well as rheumatoid arthritis, or in a setting of hematopoietic and solid organ transplantation, or with use of certain medications, including immune checkpoint inhibitors. Environmental factors, such as acquired lymphoproliferative disorders or viral infections, also contribute to development of autoimmune hemolytic anemia, with CLL, non-Hodgkin's lymphoma, being the most common, with CLL being the most common cause of lymphoproliferative disorders associated with warm autoimmune hemolytic anemia, and non-Hodgkin's lymphoma and Hodgkin's disease being common, fairly less common. Viral infections, including HIV, hepatitis B and C, parvovirus, and more recently, COVID-19 infection, have been associated with autoimmune hemolytic anemia development as well. So to summarize, In about 50% of cases, the autoimmune hemolytic anemia is idiopathic, meaning that there is no known associated condition that can potentially be accounted for the pathogenesis. In about 20% of cases, autoimmune hemolytic anemia is associated with lymphoproliferative disorders, including CLL in 5 to 10% of cases. Waldenstrom's macroglobulinemia was seen in 16% in this particular study. Non-Hodgkin's lymphoma, seen in about 2% of cases, but angioimmunoblastic T-cell lymphoma is actually a common subtype among the non-Hodgkin's lymphomas that is associated with hemolytic anemia. And autoimmune hemolytic anemia is seen in the context of Hodgkin's disease in about 1 to 2% of cases. About 20% are seen in association of autoimmune disorders with lupus, antiphospholipid syndrome, and ulcerative colitis being the most common. Then about 10% of cases are other etiologies, such as infections, drug-induced autoimmune hemolytic anemia, solid tumors, including ovarian dermoid cysts, hematopoietic and solid organ transplant, and pregnancy. So Bruno, how do you diagnose autoimmune hemolytic anemia?
The diagnosis of autoimmune hemolytic anemia starts with patient presentation and with the patient complaining specific symptoms regarding anemia and hemolysis. Most symptoms are generic and not really specific, including fatigue, asthenia, shortness of breath, worsening of a previous cardiac discomfort or other cardiac symptoms and signs, and other are more specific for hemolysis, like dark urine, jaundice due to increased bilirubin levels. Starting on these symptoms and patient presentation, we perform some laboratory tests. First, the complete blood count, which would show decreased hemoglobin level, which is the definition of anemia. And then we also check for hemolytic markers, which include lactate dehydrogenase levels, bilirubin, particularly unconjugated bilirubin, the levels of reticulocytes, which should be reported as absolute number and not only as the percentage of red blood cells, and also decrease the levels of haptoglobin, which is a scavenger for hemoglobin and which would become reduced during active hemolysis. The degree of alteration of these hemolytic markers may be different across the various forms of autoimmune hemolytic anemia. In particular, patients with warm autoimmune hemolytic anemia generally have a more acute presentation because hemolysis occurs at 37 degrees, which is body temperature. So active hemolysis may destroy a huge number of red blood cells and lead to a very severe anemia with less than 6 grams per deciliter hemoglobin level in most of the patients at presentation. Usually, LDH levels are particularly increased during the active phase of the disease and at onset, whilst symptoms like acrocyanosis or Raynaud phenomena are less frequent in patients with warm autoimmune hemolytic anemia and more typical of patients with cold agglutinin disease. Additional signs of symptoms like splenomegaly or lymph node enlargements or signs of skin reactions or urticaria, angioedema, arthralgia may be present if associated conditions are present together with autoimmune hemolytic anemia and should raise the suspect of an associated condition because, as we saw in the previous slides, autoimmune hemolytic anemia may be secondary to associated conditions in more than 50% of cases. So the diagnosis of autoimmune hemolytic anemia follows a long flow chart, as you can see in this slide, which begins with patient signs and symptoms and also with a careful anamnesis, patient history, medication history, because we saw that also medications may be associated with the development of autoimmune hemolytic anemia, but also with the family and personal history, particularly from the very beginning of a patient's life, because sometimes patients presenting with acute hemolysis in adulthood may still have signs of chronic hemolysis, and if correctly investigated, may have features of congenital hemolytic anemias. So it is very important to take into account even congenital forms in the differential diagnosis. Then we focus on the hemolytic nature of the anemia by evaluating the single markers of hemolysis, reticulocytes, unconjugated bilirubin, reduced aptoglobin, and increased LDH. But as we can see on the right part of the slide, in the green boxes, all of these hemolytic markers have some confounders, because, for example, unconjugated hyperbilirubinemia may be observed even during Gilbert syndrome, or may be observed even in patients with liver cirrhosis or liver disease. The same can be said for LDH. Increased LDH may be observed during various diseases, including muscle problems, muscle injuries, liver disease, but also, for example, myocardial infarction or pneumonia or other hypoxia conditions. So all of these markers should be assessed in the clinical context to exclude the possible confounders. The next step would be the direct antiglobulin test, which is the pivotal test to diagnose autoimmune hemolytic anemia. It is generally performed with polyspecific anti-sera in most of laboratories, which means that in the same tube you would put anti-IgG and anti-complement anti-sera to detect immunoglobulin G or complement fractions directly adherent on the surface of patients' erythrocytes. This is called direct antiglobulin test or Coombs test, direct Coombs test, because it evaluates the presence of the autoantibodies directly adherent on patients, so autologous erythrocytes. This test is performed by using patients' erythrocyte, putting them inside a tube containing anti-IgG or anti-complement fraction anti-sera, and the positivity of this polyspecific direct antiglobulin test would give the diagnosis of autoimmune hemolytic anemia. But it doesn't tell us whether it is a warm form or a cold form or a mixed form that we saw in the previous classification of autoimmune hemolytic anemia. So it is pivotal to also perform the direct antiglobulin test with monospecific anti-sera, which means that in different tubes we would assess patients' erythrocytes together with anti-IgG anti-sera, anti-complement fraction, anti-IgM, anti-IgA immunoglobulin, and so on, so that we will be able to unravel the exact positivity of the direct antiglobulin test. In particular, in patients with warm autoimmune hemolytic anemia, we would have a direct antiglobulin test positive for IgG only, or in about 30% of cases, a direct antiglobulin test positive for IgG and complement at low titer. In addition, we can perform the indirect antiglobulin test, which is called the indirect Coombs test. This test doesn't evaluate the patient's erythrocytes, but evaluates patient serum against donors' erythrocytes to assess whether in patient serum we have circulating autoantibodies or alloantibodies. So the indirect antiglobulin test is very important to unravel the presence of alloantibodies that may be particularly harmful when you need to transfuse your patients, because they may lead to transfusion reactions. Also, it can be used to evaluate patients' autoantibodies and to assess the specificity of these autoantibodies. So to unravel whether these autoantibodies are directed against RHA system or I system, I antigens, P antigens, and so on. So these are the two tests that are pivotal for the diagnosis of autoimmune hemolytic anemia, and the monospecific DAT for the diagnosis of warm autoimmune hemolytic anemia. If the direct antiglobulin test with monospecific antisera is positive and allows the diagnosis, we are happy with the diagnosis of warm AIHA. But it may happen that we have a small number of autoantibodies, or maybe that these autoantibodies have low affinity for our erythrocytes, for patients' erythrocytes. In these cases, we may have a negative direct antiglobulin test with the tube test. So we need to move on, usually this is done at reference laboratories, with more sensitive techniques, like, for example, low saline solutions, washing, cytofluorimetry, and other techniques that may allow the detection of very small amounts of IgG autoantibodies, even in patients with direct antiglobulin test negative autoimmune hemolytic anemia. Even if we increase the sensitivity of the test, up to 10% of patients may remain negative at the direct antiglobulin test. In this case, we need to exclude all the other forms of autoimmune hemolytic anemia, and the diagnosis is made after a first trial of steroid therapy. So we call it the ex juvantibus diagnosis after response to steroid treatment. Next to the diagnosis, the parameters of the complete blood counts, as well as of hemolytic parameters at diagnosis of autoimmune hemolytic anemia, may give us hints about the severity of the disease, but also on the probability that these patients would relapse after the first line of treatment. And this is based on a large retrospective analysis of more than 300 patients, where it was shown that the levels of hemoglobin at diagnosis is the most important, the most relevant predictor of outcome in patients with autoimmune hemolytic anemia, including patients with warm AIHA. In particular, it was estimated that the risk of relapse is significantly higher in patients with less than 6 grams per deciliter hemoglobin, more than 3 times higher than patients with hemoglobin comprised between 8 and 10, and with patients with higher levels of hemoglobin. In addition, it was observed that patients with warm autoimmune hemolytic anemia that also activated complement and showed a direct antiglobulin test positive for both IgG and complement at low titer are at higher risk of relapse. These patients usually also show a more severe disease at diagnosis, so they require higher attention, particularly during the treatment phase, where which we will talk later.
So the treatment of warm autoimmune hemolytic anemia has been empirically derived and based on consensus recommendations and prior experience. And currently, the treatment of warm autoimmune hemolytic anemia, initial therapy consists of using corticosteroids, with most commonly used agent being prednisone, 1 milligram per kilogram a day starting dose. Rituximab can be considered in cases of severe disease or in patients in whom prolonged corticosteroid exposure is not desirable. The initial corticosteroid therapy is continued for at least 2 to 3 weeks. And if the response is seen after the initial therapy, then a slow corticosteroid taper over the next 3 to 6 months is reasonable, and we'll discuss it on the next slide. In patients who relapse on corticosteroid taper or fail initial corticosteroid therapy, we utilize second-line therapeutic options, which in the majority of cases is rituximab. Rituximab can be also used as a retreatment in patients who received rituximab in the first-line therapy if they had a sustained response to the first-line therapy rituximab treatment. In the third-line therapies includes splenectomy, azathioprine, mycophenolate, and cyclosporin. In patients with low reticulocyte count, we can also consider erythropoietin-stimulating agent. And finally, in multi-refractory patients, fourth-line therapies, in addition to cyclosporin, bortezomib, and danazol, fourth-line therapies can include cyclosporin, bortezomib, and danazol. It is important to consider clinical trial therapies for patients with warm autoimmune hemolytic anemia in any stage of the disease.
So, Irina, how long shall we go on with steroids?
So the first-line corticosteroids in warm autoimmune hemolytic anemia, as we've discussed, we start with prednisone 1 to 2 milligrams per kilogram per day, or a total dose of 60 to 100 milligrams a day. And we maintain this dose for at least 2 weeks and until hemoglobin is greater than 10 grams per deciliter. And this is an endpoint which is reached in about 80% of patients in 2 to 3 weeks. Once we achieved our goal, we start tapering the prednisone by 20 milligrams per week over 4 to 6 weeks until the patient is on about 20 milligrams per day. After that, the corticosteroid taper should slow down by about 5 milligrams a month for a total duration of corticosteroid therapy of 4 to 6 months. And the reason we do that is because relapses are much more common if the corticosteroids are tapered to less than 10 milligrams in less than 2 months, and if they're stopped up at less than 6 months of total duration. Despite that, we only 20 to 30% of patients remain in long-term remission after tapering prednisone. And in these patients, we should consider second-line therapies. So second-line therapies would be appropriate if there's no response to initial dose of corticosteroids after 3 weeks, or there is a relapse during or after steroid taper. A common second-line therapy for warm autoimmune hemolytic anemia is rituximab. On this slide, you can see a summary of retrospective trials of efficacy of rituximab in relapsed and refractory warm autoimmune hemolytic anemia. And as you can see, the overall response rate ranges between 65 and 100%, with complete response rate ranging between 25 and 85%. So what dose of the rituximab do we use? Here you can see progression-free survival curves from 3 different studies. On the left is an Italian study utilizing low-dose rituximab, and the top graph is referring to patients with warm autoimmune hemolytic anemia, with a relapse-free survival of approximately 75% at 34 months. Figure in the middle from a first-line trial of rituximab use in warm autoimmune hemolytic anemia. And this trial utilized 375 milligrams per meter squared, which is a conventional dose we use in lymphoma-directed therapies. This was administered weekly for 4 total doses. And again, you see very similar progression-free survival rates. The last trial utilized rituximab 1,000 milligrams in 2 divided doses on day 1 and day 15, which is a dose that's used commonly in rheumatologic literature in patients with lupus as well as rheumatoid arthritis. And again, you can see very similar progression-free survival curve compared to placebo. Okay, so according to the guidelines, either 375 milligrams per meter squared or 1,000 milligrams day 1 and day 15 are appropriate doses for the first-line therapy, but particularly in the resource-poor areas, rituximab 100 milligrams weekly times 4 can be considered, since the amount of abnormal lymphocytes is much lower in autoimmune disorders compared to lymphoproliferative disorders. So on this slide, you can see the responses to rituximab over time. And you can see that most patients respond to rituximab within 4 to 6 weeks, but the maximum response is seen at about 3 months. However, responses can also be seen even in the first week. Unfortunately, those responses are not durable, with 25 to 50% of patients relapsing at 1 to 2 years, raising the need for further therapies after rituximab failure. So, Bruno, which dose of rituximab do you use for warm autoimmune hemolytic anemia?
So usually we tend to use the low dose, 100 milligram per week for 4 weeks, in patients with direct antiglobulin test positive for IgG only. Whilst in patients with a direct antiglobulin positive for IgG and complement fraction, we tend to use the standard dose of 375 milligram per square meter.
Splenectomy used to be a second-line therapy for warm autoimmune hemolytic anemia, with initial response rate of approximately 60 to 70%. Unfortunately, long-term remission rates are only about 20%. In addition, the surgical mortality rate is 0.8%, even in the modern studies. And infectious complications can be seen in a significant amount of patients, with overwhelming post-splenectomy sepsis reported in 3 to 5% of patients. This is a serious condition that has mortality rate of more than 50%. And these infections were seen even in patients who received pre-splenectomy vaccinations against encapsulated microorganisms. In addition, splenectomy is associated with increased risk of thrombotic events, which is approximately 2% within the 30 days post-splenectomy and within a year of post-splenectomy as well. This table lists current treatments of warm autoimmune hemolytic anemia with dosing schedules, as well as time to response and the risks and benefits of this particular therapy. So as you can see, prednisolone can be used at the dose 1 to 2 milligrams per kilogram per day for 3 to 4 weeks with a gradual taper. Initial response rate is seen in 80 to 90% of patients, but an estimated cure rate is only about 20 to 30% or chance of long-term remission. The time to response is usually 1 to 4 weeks, and then the corticosteroids should be gradually tapered. In severe cases of rapid hemolysis, steroid boluses, for example, methylprednisolone, 250 milligrams IV daily for 3 days can be used. The side effects of prednisolone are well known and include drug-induced diabetes or exacerbation of pre-existing diabetes, hypertension, development of peptic ulcers, osteoporosis with long-term use, risk of adrenal suppression, muscle weakness and myopathy, psychosis, poor wound healing, weight gain, as well as risk of the infections. Rituximab can be used at a conventional dose of 375 milligrams per meter squared per week for 4 weeks, but we also discussed the alternative dosing regimens. And again, initial response rate is about 80%, with relapse-free survival of about 60% at 3 years. And the time to response is 3 to 6 weeks in general. You can also use other dosing schedules. The side effects of the rituximab include infusion reactions, which are rather common and seen in about a third of patients. Most of them are mild. Neutropenia, hypogammaglobulinemia, potential concern for reactivation of underlying infections, as well as in the modern times, a concern about poor response to vaccination, including vaccination against COVID-19. Splenectomy has a cure rate of about 80%, has initial response rate of about 80%, with a cure rate of somewhere between 20 and 50%, time to response of about a week. And it's due to the associated complications in patients post-splenectomy, including infections, surgical complications. It is discouraged in patients over the age of 65 to 70 with cardiopulmonary disorders, in patients who have increased risk of thrombosis, who have associated immunodeficiency, lymphoproliferative disorder, or a systemic autoimmune disease. And in terms of the side effects, as we've discussed, serious infections are a concern in patients with splenectomy, and it is recommended that patients are administered vaccination against encapsulated organisms, including Neisseria meningitidis, quadrivalent vaccine covering genotypes A, C, W, and Y, as well as the type B, pneumococcal and Haemophilus influenza vaccine. In addition, patients should also have annual flu vaccines and boosters for the vaccines that we've discussed on an every 5-year basis. Thrombotic events are associated with splenectomy as well. Azathioprine is an agent that we generally use in a third line and beyond setting. The response rate is about 60%, but unfortunately, the data is limited to retrospective studies and case reports. It takes a little bit of time to respond to azathioprine, about 1 to 3 months. And it's useful as a steroid-sparing agent in autoimmune hemolytic anemia secondary to systemic autoimmune conditions, autoimmune hepatitis, and inflammatory bowel disease. Azathioprine is associated with myelotoxicity, particularly in patients with thiopurine methyltransferase deficiency. And it is recommended to start at a lower dose at 50 milligrams daily. And if there is no hematologic or hepatic toxicity, to increase it to 150 milligrams daily to target the appropriate response. Cyclosporin at a dose of 2.5 milligrams per kilogram twice daily is associated with response rate of about 60%, again, in mostly retrospective studies, with time to response of 1 to 3 months, and again, useful as a steroid-sparing agent, particularly in autoimmune hemolytic anemia in association with other autoimmune disorders or Evans syndromes, or in cases of bone marrow failure. And the adverse events that we see with cyclosporin is kidney toxicity, hypertension, risk of the infections, nausea or hypertrichosis or increased hair loss. Cyclophosphamide is probably my least favorite treatment for warm autoimmune hemolytic anemia, although the response rate is reasonable at 50 to 70%. It does take 2 to 6 weeks for it to respond. The drug is very myelosuppressive and associated with increased risk of infection, secondary malignancies, hematuria, and teratogenicity, as well as infertility. But it can be considered in severe, highly hemolytic conditions, particularly in association with lymphoproliferative disorders or connective tissue disorders. And finally, mycophenolate, 500 milligrams daily, has response rate of 25 to 100%, again, in the retrospective small case series with a time to response of 1 to 3 months, and has been used in pediatric setting and has the side effects of headache, nausea, and diarrhea. Dr. Bruno Fattizzo and Dr. Bartolini in 2018 demonstrated that reticulocytopenia can be seen in as many as 20% of adults and 39% of children with autoimmune hemolytic anemia. And as many as 50% of patients have inadequate reticulocyte count and inadequate erythropoietic response to hemolysis. And this is particularly seen in patients with lower hemoglobin levels, with hemoglobin less than 6 being more common. So they followed this with a study of efficacy of recombinant erythropoietin in autoimmune hemolytic anemia, in which they looked at 48 cases of autoimmune hemolytic anemia treated either with erythropoietin alpha of 40,000 units a week or darbepoetin at a dose of 20 to 300 micrograms a week. They were able to see responses of about 70% in refractory autoimmune hemolytic anemia, particularly in patients with severe anemia, low hemoglobin level, low endogenous erythropoietin, and when the erythropoietin was used early in disease, as opposed to in more refractory conditions.
And Irina, what dose of recombinant erythropoietin would you use in a patient with warm autoimmune hemolytic anemia?
So we typically use RNS because this is what is on formulary in our institution. And I start with 100 milligrams every 2 weeks and adjust after 4 weeks. But I also have been using Procrit in patients who self-administer the medication at home at a dose of 40,000 units weekly.
Autoimmune hemolytic anemia may be considered like a multisystemic disorder with potential life-threatening complications. This may occur at the onset of the disease, so very close to the diagnosis, or during the course of the disease. Some of these complications may be related to the hemolytic process itself. Some other may be more linked to the iatrogenic effect of the immunosuppressive therapy administered to the patient. The most feared complications include infections and thrombotic complications. And there are some more rare forms, like, for example, acute renal failure, that may occur during very, very severe and acute hemolysis. Also, other complications like ischemic complications due to very extremely low levels of hemoglobin may be observed in a small fraction of patients that would require admission to the ICU. It has been calculated that some of these complications increase the risk of mortality in patients with autoimmune hemolytic anemia. And in the box on the right, you can see the various hazard ratios calculated for the different disease complications. For example, we see Evans syndrome, which has a hazard ratio of 8, which means that it gives you 8 times a higher risk of mortality in a patient with autoimmune hemolytic anemia and Evans syndrome. Acute renal failure 6 times, infections against an hazard ratio greater than 4, and multi-treatment, so a patient requiring several lines of treatment, also has an hazard ratio of 4, which means that a patient receiving multiple lines of therapy would have an increased risk of complications and autoimmune hemolytic anemia-related mortality. Thrombotic events are usually not associated with mortality, possibly because we are becoming more and more aware about thrombotic complications, and prompt prophylaxis may be established. So focusing on thrombosis in warm autoimmune hemolytic anemia, there are several reports in the literature, mostly retrospective studies on large series of warm autoimmune hemolytic anemia patients, showing a prevalence of thrombosis ranging from 10 to 20% of patients. These thrombotic complications have been linked to the first part of disease course, so usually occur during the active hemolysis, very close to disease diagnosis, usually within the first 3 months from diagnosis. Thrombotic events are mainly interest the venous district and are deep venous thrombosis and pulmonary embolism, but also atypical thrombosis may occur. Some markers that may predict the occurrence of thrombosis in patients with warm autoimmune hemolytic anemia are the levels of hemoglobin, so very severe anemia, less than 6 grams per deciliter at onset, the presence of active intravascular hemolysis as shown by LDH levels increase, generally greater than 1.5 per the upper limit of normality, and history of treatments that may be related to thrombotic risk. As we heard from the the section on treatment, splenectomy is particularly linked to a thrombotic risk. Also associated conditions like, for example, solid tumors, transplant, but also the positivity for antiphospholipid autoantibodies may be linked with increased risk of thrombosis in patients with autoimmune hemolytic anemia. However, as we mentioned before, it doesn't seem that thrombosis increase the risk of mortality in patients with warm autoimmune hemolytic anemia. And this is probably thanks to the consideration, to the awareness regarding the possible prophylaxis of DVT in patients with. Recently, we studied our series of patients with autoimmune hemolytic anemia to evaluate some predictors of thrombosis, and we confirmed that low hemoglobin, so less than 8 grams per deciliter at diagnosis, and active hemolysis with LDH levels greater than 1.5 per the upper limit of normal range are particularly linked with thrombosis events. So we proposed an active prophylaxis, antithrombotic prophylaxis with low molecular weight heparin in patients presenting with hemoglobin less than 8 grams per deciliter, increased LDH level greater than 1.5 per the upper limit of the normal range, and in patients with associated risk factors for thrombosis. And as we can see in these graphs, going from A to F, in the various situations, the presence of the presence of multi-treatment, particularly requirement of a second line with rituximab in box B, or the requirement of cyclophosphamide, as we can see in box D, are all factors associated with higher risk of thrombosis, which means that in patients with chronic relapsing autoimmune hemolytic anemia, we need to be even more aware of thrombotic risk and consider prophylaxis every time the patient presents with low hemoglobin levels and increased LDH. Another complication that is linked with increased mortality in autoimmune hemolytic anemia is infection. Infections may be either the trigger of autoimmune hemolytic anemia development, as we heard in the part of the pathogenesis of autoimmune hemolytic anemia, because of increased immune activation, molecular mimicry, and many possible pathogenic mechanisms. But infections may also be a complication of autoimmune hemolytic anemia. And this is important because infections are mainly iatrogenic, so linked to the burden of immunosuppressive treatment that we administer to our patient. What can we do? First, we can try to spare immunosuppression, particularly in patients with associated conditions predisposing to infections like immunodeficiencies, and also by using treatments like recombinant erythropoietin or intravenous immunoglobulin that may be used in acute phases, sparing the immunosuppressive treatment. But also we need to assess the serology for some agents, some infectious agents, like, for example, hepatitis B virus or hepatitis C virus, to establish a prompt and correct prophylaxis before administering immunosuppression. In particular, in case of chronic hepatitis B infection, it is mandatory to establish a prophylaxis, an antiviral prophylaxis, before administering rituximab. That should be continued until 18 months after the end of rituximab course. In case of hepatitis C virus positivity, we may consider to eradicate hepatitis C virus with eradicating therapy before candidating the patient to rituximab, for example, or more toxic immunosuppressants. And then we have other infectious agents, like, for example, Mycobacterium tuberculosis or Pneumocystis jirovecii, then that also requires to be assessed before administering high-dose treatments, particularly for a long period, as we do in warm autoimmune hemolytic anemia, because prophylaxis may be established. And finally, of course, encapsulated bacteria should be prophylacted by the administration of vaccines in patients candidate to splenectomy. An important association is Evans syndrome. As we mentioned, Evans syndrome may be associated with increased mortality in patients with warm autoimmune hemolytic anemia. This is the clinical association of concomitant or subsequent development of other autoimmune cytopenias, including immune thrombocytopenia and occasionally autoimmune neutropenia. Evans syndrome is diagnosed in a patient presenting with at least two cytopenias, two immune-mediated cytopenias, and the diagnosis is established by the direct antiglobulin test for autoimmune hemolytic anemia. But it's much more difficult for the other two cytopenias because both immune thrombocytopenia and immune neutropenia are diagnoses of exclusion. So we need to exclude all the other possible causes virtually of neutropenia and thrombocytopenia. In fact, whilst the direct antiglobulin test has a high sensitivity and specificity, antiplatelet antibodies and anti-neutrophil autoantibodies are tests with low sensitivity and low specificity. It is even more important to assess for a secondary Evans syndrome, so an associated condition in this context, because the association are exactly the same types we mentioned for warm autoimmune hemolytic anemia. So other autoimmune disease, primary immune deficiencies, lymphomas, and so on. But it is very important to reckon the associated condition because we may tailor treatment according to the presence of an associated condition and avoid life-threatening complications. In fact, in patients with Evans syndrome, the risk of thrombosis and the risk of infection is about twofold that observed in warm autoimmune hemolytic anemia patients. So in patients with isolated autoimmune hemolytic anemia, the risk is lower than in Evans syndrome. So this tells us that we need to further tailor treatment in these patients, to further administer proper prophylaxis, antithrombosis and non-infectious prophylaxis in these patients, and to avoid a huge burden of immunosuppression. As previously mentioned, reticulocytopenia, so inadequate bone marrow compensation of hemolysis, may be considered a complication of autoimmune hemolytic anemia, since about half of patients with very severe anemia with hemoglobin less than 6 grams per deciliter may display inadequate reticulocyte counts. And for these patients, the use of recombinant erythropoietin may be considered. In a recent series of patients admitted to the ICU because of autoimmune hemolytic anemia, patients mainly displayed very severe anemia, and also most of the patients had inadequate bone marrow compensation. More than 80% of patients had inadequate bone marrow compensation as displayed by inadequate reticulocytosis. And in these patients, only 22% received the recombinant erythropoietin. This is a retrospective series, but this is something, a clinical picture that we need to modify by a prompt and quick use of erythropoiesis-stimulating agents, even in this setting. So Irina, and for patients relapsing or refractory to rituximab or who are not candidate to splenectomy, what are the future developments?
This is a very exciting time in treatment of warm autoimmune hemolytic anemia with many novel therapeutic options in development. And the way we can think about the new therapeutic options in development of warm autoimmune hemolytic anemia is by the site of action. So so we can target the immune activation and cytokine secretion with agents such as alemtuzumab, which is an anti-CD52 antibody, MMF, which is a purine synthesis inhibitor, and sirolimus, which is an anti-mTOR. The B cell function can be suppressed by a number of agents. In addition to rituximab, the novel therapeutic approaches include BAFF inhibitors, proteasome inhibitors such as bortezomib, other plasma cell-directed therapies such as daratumumab, agents that act through B-cell receptor signaling pathway, which include BTK inhibitors such as ibrutinib or rilzabrutinib, PIK3 kinase inhibitors such as adalasib or parsaclisib, anti-BCL2 agents such as venetoclax. In addition to their role in the B-cell inhibition, agents that target the B-cell receptor signaling pathways such as ibrutinib, BTK inhibitors, PIK3 kinase inhibitors, as well as SYK inhibitor, fostamatinib, that also target and play a role in red cell phagocytosis. And inhibition of these pathways will have an almost immediate effect on abrogation of hemolysis due to anti-phagocytic properties of these agents. In addition, we can optimize the bone marrow function by using agents such as erythropoietin, danazol, or luspatercept. And there are agents predominantly in patients who have evidence of complement activation and complement-mediated lysis, agents targeting complement pathway, such as C1q inhibitor, annexon 05, APL2, or pegcetacoplan, a C3 inhibitor can be used. So this is a summary of novel therapies in warm autoimmune hemolytic anemias. Some of these agents are commercially available and some are still in development. So as mentioned, alemtuzumab is a CD52 antibodies that showed efficacy in secondary autoimmune hemolytic anemia in case reports. Similarly, in patients who had autoimmune hemolytic anemia in a setting of hematopoietic stem cell transplant, a CD38 antibody daratumumab has been shown to be effective, and it's currently being evaluated in prospective clinical trials. Ofatumumab is a CD20 antibody that also has been shown to have efficacy in secondary autoimmune hemolytic anemia in a context of lymphoproliferative disease. Some new agents on the market are, or some new agents in development, rather, are BAFF inhibitors or BAFF-APRIL inhibitors, which inhibit the B cell function and development, and they include ianalumab and povetacicept, which are currently in phase 3 and phase 1 trials. And finally, a CD19 monoclonal antibody, obexelimab, is currently being evaluated in phase 3 clinical trial as well. B-cell receptor pathway and Fc gamma signaling inhibitors include ibrutinib, rilzabrutinib, and venetoclax. And IgG-mediated phagocytosis inhibitors include fostamatinib, sovleplenib, which are both SYK inhibitors and currently being evaluated or have completed evaluation in phase 3 clinical trials. Nipocalimab is a FcRn monoclonal antibody that's with the trial currently ongoing, which is a phase 2/3 randomized clinical trial. Similarly, arlinumab is a FcRn monoclonal antibody that's currently in phase 2 clinical trials. And finally, complement inhibitors, as we've discussed, C1q inhibitor is currently in a clinical trial with warm autoimmune hemolytic anemia as well as cold agglutinin disease. Eculizumab has shown efficacy in cold agglutinin disease and mixed autoimmune hemolytic anemia in case reports, as well as a phase 2 studies. And eculizumab, as everybody knows, is an agent currently on the market, which targets C5 complement and is used in atypical HUS and paroxysmal nocturnal hemoglobinuria, among most commonly used in those conditions. And pegcetacoplan, which is a C3 inhibitor, has shown some preliminary efficacy in the phase 1/2 trial in warm autoimmune hemolytic anemia, as well as cold agglutinin disease. Bortezomib is a proteasome inhibitor that showed efficacy in case reports and in a phase 2 trial in warm autoimmune hemolytic anemia and cold agglutinin disease. So next, we'll look into these agents a little bit more in detail. So B-cell receptor signaling pathway is an important pathway that is essential for normal B-cell development, selection, survival, proliferation, and differentiation of B-cells into antibody secreting cells. And this regulation at various steps of B-cell receptor signaling pathway is seen in a number of conditions, including congenital immunodeficiencies, as well as autoimmune conditions, leukemia, and lymphoma. And this pathway is controlled by several key enzymes, including PI3K delta, SYK, and BTK, with expression of these enzymes limited mostly to hematopoietic cells and functions mostly in the B cells. So therefore, targeting B-cell receptor signaling pathway is a great mechanism to limit the toxicity and optimize the efficacy. So SYK is a cytoplasmic tyrosine kinase, which is activated by binding of the antigen to the B-cell receptor. And SYK is required for signaling downstream of the B-cell receptor, and as we discussed, proliferation, maturation, and survival of the B cells. But in addition, SYK is essential for FC receptor-mediated phagocytosis of antibody-coated red cells. And the activation of the SYK receptor leads to phosphorylation of SYK. When we inhibit SYK, in addition to blocking B-cell activation, decreased ability of B cells to serve as antigen-presenting cells to T cells, and decreased stimulation of T cells to stimulate B cells to secrete antibodies, as well as blocking of antibody affinity maturation and IgG class switching. SYK inhibition additionally inhibits FcR-triggered SYK-dependent cytoskeletal rearrangement during phagocytosis, which has been proposed to be the main mechanism of action in ITP, as well as warm autoimmune hemolytic anemia. So fostamatinib was the first agent of the class, which was approved for ITP in April of 2018. And it has an orphan drug designation in warm autoimmune hemolytic anemia. Fostamatinib was studied in a phase 3 randomized double-blind placebo-controlled clinical trial in patients with warm autoimmune hemolytic anemia who progressed on at least one prior therapy. The primary endpoint of this trial was achievement of hemoglobin greater than 10 and at least 2 gram per deciliter improvement of hemoglobin from the baseline. The initial results of the study revealed the overall response rate of 35.8% in fostamatinib group and 26.7% in the placebo group in a pre-specified analysis. When the study was, when we looked at the results in more detail, we were actually able to see that there is a subgroup of patients in Eastern Europe who had a very high placebo response rate, as high as 40%, which was about the same as response rate for fostamatinib. In contrast, the patients in the United States, Canada, Australia, and Western Europe had a fostamatinib response rate of 32%, which is in line with the phase 2 trial data, and a placebo response of 28%. So the reanalysis of the trial, which excluded 2 patients from the placebo group who had no evidence of hemolysis, actually showed a response rate of 33% in fostamatinib group and 14% in a placebo group. And this difference was clinically significant. So the initial negative results of the trial were attributed to high placebo response rate in Eastern Europe. So next we will talk about the FcRn inhibition. And FcRn is an MHC class 1 Fc gamma receptor, which consists of 2 subunits, alpha and beta-2 microglobulin, which allows binding of IgG and albumin to the surface of the receptor, and is responsible for IgG transplacental transport, which is how initially this receptor was discovered. This receptor is responsible for passage of antibodies from mother to the fetus. Subsequently, it was also discovered that IgG recycling and transport, as well as albumin recycling and transport, are dependent on the FcRn receptor. And the way the FcRn receptor plays a role in IgG recycling and transplant is by pH-dependent intracellular endosome shielding of the IgG molecules, at preventing degradation of the IgG molecules in the endosome and recycling them back to the surface. So blocking the FcRn receptor will result in inhibition of recycling of IgG and decrease in both pathogenic as well as normal antibodies. So nipocalimab is an inhibitor of the FcRn receptor pathway, which is currently being evaluated in a phase 2/3 randomized double-blind placebo-controlled clinical trial. In a preliminary studies in myasthenia gravis, nipocalimab showed substantial and rapid reductions in serum total and pathogenic IgG antibodies, which were correlated statistically significant with symptom improvement. And you can see the data on the right. In an open label phase 2 Unity trial, the results of which just became available, there were positive results from treatment of pregnant women who were at high risk for severe hemolytic disease of the fetus and newborn. So ENERGY trial is a 24-week phase 2/3 randomized control trial with a planned accrual of 111 patients and a primary endpoint of durable improvement in hemoglobin. And the enrollment in this trial is currently ongoing. The potential benefit of the trial is the fact that the nipocalimab, while blocking recycling of pathogenic as well as normal antibodies, it does not reduce the production of new antibodies in response to infection. We'll just briefly discuss BAFF inhibition. So BAFF mediated or B cell activating factor and BAFF mediated signaling is very important for B cell maturation, proliferation, and survival. BAFF can bind to BR3 receptor, BCMA receptor, or TACI receptor to perform these signaling function in B cell survival, which are also, these functions are also important in plasma cell survival, as well as T cell independent responses and isotype switching. There's currently 2 BAFF inhibitors that are being evaluated in warm autoimmune hemolytic anemia. Ianalumab is a monoclonal antibody directed against the BAFF receptor, which causes B cell depletion via direct lysis of B cells, as well as BAFF receptor blockade, and is currently in a phase 3 trial in warm autoimmune hemolytic anemia. And povetacicept inhibits BAFF as well as proliferation-inducing like and APRIL, and reduces antibody-secreting plasma cells, as well as B cells, and is currently in a phase 1b trial in warm autoimmune hemolytic anemia. And finally, complement inhibition in warm autoimmune hemolytic anemia has become a potential therapeutic target, with approximately 20 to 50% of patients with warm autoimmune hemolytic anemia exhibiting complement involvement. And as discussed previously, complement involvement can be associated with lower hemoglobin levels and higher need for subsequent therapies. A preliminary study, phase 2 trial with pegcetacoplan revealed that inhibition of C3 resulted in normalization of markers of intravascular and extravascular hemolysis in patients with autoimmune hemolytic anemia. And currently, there is a clinical trial ongoing with a C1q inhibitor. The drug is called Annexon 005. Pegcetacoplan is also being studied in a phase 2 trial in warm autoimmune hemolytic anemia, as well as cold agglutinin disease.
So when, during the disease course of a patient with warm autoimmune hemolytic anemia, would you consider suggesting the enrollment in a clinical trial?
So thank you for this question. It's a very important question, Bruno. I'm a big proponent of clinical trials, and given very high relapse rate of warm autoimmune hemolytic anemia, I would consider enrollment in a clinical trial after a failure certainly after a failure of rituximab therapy, for patients who are not candidates for splenectomy or would prefer not to do splenectomy. So second line and subsequent lines of therapy would be very reasonable to consider enrollment in clinical trials. Particularly in the current time where, again, rituximab use is less favored due to suboptimal response to vaccination in the setting of pandemic.
So to conclude, the clinical severity of the warm autoimmune hemolytic anemia is influenced by autoantibody class, ability of antibodies to activate complement, and adequacy of bone marrow compensatory response. The direct antiglobulin test, particularly with monospecific antisera, is the cornerstone of diagnosis, but can be negative in up to 10% of cases, requiring more sensitive methods, reference laboratories, and also the use of ex-ubantibus diagnosis through steroid treatment. The identification of secondary etiologies is essential, as therapy can be different in these cases.
So first-line therapy for warm autoimmune hemolytic anemia includes steroids with slow taper to prevent the relapse. Rituximab is the preferred second-line therapy and should be considered in first-line in the select cases of severe disease and when the prolonged therapy is not desirable with corticosteroids. Erythropoietin can be a very effective therapy in patients with inadequate erythropoietic response.
Many complications may be associated with autoimmune hemolytic anemia. Particularly thrombosis is a common complication in up to 20% of cases, and thromboprophylaxis is important in high-risk situations like patients with less than 8 grams per deciliter and LDH levels greater than 1.5 per the upper limit of normal range and associated conditions. Infectious complications are often iatrogenic and should be attentioned.
So new therapeutic agents directed at pathophysiology of the disease, including B-cell and plasma cell-directed therapies, phagocytosis inhibition, and IgG reduction are in progress.